I've been asked this morning to speak a little bit about this topic of too much exercise, and when I reflect on this concept, it strikes me that the concept of whether or not you can get too much of a good thing is right where ECG screening was about a decade ago, where this dominates the debate topics in most of the national meetings. And really what that means is that this is a field that we don't have enough data yet to answer with certainty. So what I'm going to try to do is present this topic with as much equipoise as possible. And again, the question we're going to ask is whether or not you can get too much of a good thing and actually harm yourself from exercising. So I don't know if any of you remember where you were on November 27th, 2012. I don't remember that night, but I remember the next morning, 485 emails in my inbox, and they were all generated by this editorial that was published in the Wall Street Journal entitled "One Running Shoe in the Grave." And the editorialist writes, "Running can take a toll on the heart that essentially eliminates the benefits of exercise. Running too far, too fast, and for too many years may speed one's progress toward the finish line of life." And this editorial was based on a medical editorial that was shortly there to follow in the cardiology journal Heart, which is a British journal. And here indeed is the editorial. It's called "Run for Your Life at a Comfortable Speed and Not Too Far," written by two relatively well-known American cardiologists, Jim O'Keefe and Carl Lavie. And in this editorial, they use basically four argument lines: an evaluation of some older epidemiologic data, some discussion of case reports, including this gentleman here. Anyone parenthetically know who this guy running with a shirt around his neck is? Anyone read the book Born to Run? This is Caballo Blanco, who was the famous gringo in that book who lived down in the Copper Canyons and ran hundreds of miles, who dropped dead running. Turns out he was suffering from a viral infection at the time he died, and that was probably what caused him to die, not too much running. But they also talk about this issue of cardiac damage and then some new emerging epidemiology to make the claim that too much exercise over too much time can kill you. I will point out that this was a commissioned, internally peer-reviewed article that none of us in the field that think about this had an opportunity to see. Nonetheless, it's an entertaining read, and if you want to watch the TED Talk, here is the link to that. When you look carefully at the science presented in this editorial, the vast majority of it doesn't stand a rigorous test. And so it's really not, from the perspective of scientific rigor, a logical editorial, but indeed it raises an important question. And I do think that for the most part, where there's lots of smoke, there's usually a little fire. So I think it's reasonable to step back and ask the question, does too much exercise over too much time hurt your heart? And I would submit, importantly, if it does so, does it affect morbidity and mortality? And if so, what does this pathology truly look like? So why talk about this again? There are three basic reasons to ask this question. The first is that there are some emerging epidemiologic data which are now focusing for the first time really on the high ends of fitness and teaching us a lot about what happens to people who push their bodies hard. There are anecdotal observations, as we talked about yesterday, of physically fit people dying during sport, and perhaps this may be due in some part to some element of sport-induced cardiovascular disease. And then there's a lot of observational data now describing, quote, cardiovascular pathology among athletes and athletic patients. And if these three things were to converge, perhaps there's a syndrome of cardiovascular abnormalities that may even be caused by chronic exposure to high volumes of exercise. So to begin this discussion, I think it's important to return to the concept of dose response. Medical School 101 tells us that when we expose an organism to any stimulus, particularly as clinicians when we give a patient a medication, we can define that response by two curves, an efficacy curve and a toxicity curve. And when we give someone a medication, we hope that they're going to find themselves in this margin of safety where they get benefit and avoid toxicity. But in fact, when you apply this to populations, you're all well aware of the fact that there are benefit outliers. People that get lots of benefit despite very little exposure, and people that get no benefit despite, quote, toxic level exposures. And similarly, there are toxic outliers. So unfortunately, this very oversimplified dose-response curve doesn't explain exercise in a nutshell. And in fact, when we talk about the body's response to exercise, we probably need to consider several different types of curves. And let me give you a couple of examples. So the straight linear curve here labeled A is probably a reasonable dose-response curve to explain race performance. The harder you train, the faster you race. This asymptotic curve here probably explains cardiovascular risk factors. You get good risk factor modification from starting exercise, but above a certain point, you're not going to do more for your blood pressure, your cholesterol. This bimodal curve here on the bottom is actually a reasonably good dose response curve to explain weight loss and exercise. You stimulate weight loss by going from doing something if you've been doing nothing, but in order to maintain weight loss over long periods of time, you have to actually do quite a bit of exercise. And then my favorite one, this bell-shaped curve, explains the relationship between exercise and, of course, marital success. Too much exercise, if you're not home, your spouse is no longer going to stick around with you. So when people ask the question, what is the relationship between exercise and some health outcome, it's important to specify what the health outcome is. For those of you that are interested in thinking about exercise dose as part of your clinical practice, this is an algorithm that one of my junior colleagues and I put together a year or two ago, was published in Circulation, which makes the claim that every single patient with whom we interact with, whether they're athletic or not, that assessing physical activity habits should be part of every single visit, and that if you do so, you can put people into one of three basic camps. Those that fail to meet physical activity recommendations, and again, just as a refresher, current U.S. Health Preventive Task Force Service recommendations would suggest 150 minutes of moderate intensity aerobic activity a week or 75 minutes of vigorous physical activity. And as you are well aware, our problem in America is not too much exercise, but too little exercise. 80% of Americans fail to meet these physical activity recommendations. And indeed, when we meet these folks, our job is to understand why that is the case, address barriers, and help them to move. There are some patients that meet these physical activity guidelines, and those folks, reassurance and reinforcement is great. And then in our practice, our sports cardiology program, most of our patients exceed these guidelines, and this is really what the talk is all about, and this is where we have discussions about potential risk and think about the use of diagnostic risk stratification. So what I want to do with you is ask three basic questions, and you'll note here, I don't know why those lines turned black, that I've underlined the word cause. I want to ask the questions, do endurance sports cause arrhythmia, cause cardiomyopathy, and cause coronary artery disease? So let's start with arrhythmia. Not a diagnostic dilemma here. Where's Jack? Jack gets to read all of our ECGs. Jack, what's the diagnosis here, Jack? This is something you see in pediatric patients all the time. Negative. So, no. So I don't want to make your life miserable. So this is a 52-year-old marathon runner with decreased exercise tolerance who comes into the clinic with atrial fibrillation. We just had a great session, and Jack reminded us that he does not see this as a pediatric cardiologist, so I just put him on the spot. But this is something that we see very, very frequently in our aging endurance athletes. There have now been a number of well-done observational case control studies which all make come to the same conclusion, and that is that people that push their bodies hard into their fourth, fifth, and sixth decades of life are at increased risk of atrial tachyarrhythmias, including fibrillation and flutter. I think Jordan's going to talk about this in some detail afterwards, so I'm not going to belabor this, but one study that deserves mention, which I think is probably the most elegant of studies to date, comes from Northern Europe. It is a retrospective study that was published out of Sweden, examining participants in the Vasaloppet, which is a 90-kilometer cross-country ski race. And over an extended period of time, about a decade, these investigators were able to track 50,000 participants. And what they did is ask the question, does the number of times these guys came to the race, meaning how committed they were as endurance athletes, and the speed with which they finished the race, how good they were, predict incident arrhythmia? And indeed it did. The faster they were and the more times they came to the race, the more likely they were to develop atrial fibrillation, which was the dominant rhythm problem in this group. So why does it occur? The classic teaching is probably that it's a function of atrial dilation. When you move large quantities of blood through the heart over many years, the atrium get bigger, and maybe big atrium causes atrial fibrillation in masters athletes. I would submit that it's almost certainly more complicated than that, and there's a long list of things that go into this pathogenesis. There are certainly neurologic issues, including vagotonia coupled with sympathetic surges, intermittent left atrial hypertension, inflammation, genetics, and then some of the more epigenetic things like alcohol consumption, caffeine, and of course psychosocial stress. The strongest association at this point that we have between endurance sport and any pathology really lies with AFib. I think the data are quite clear that our aging patients who engage in these sports are at increased risk of this outcome. I still don't think we know with certainty how much of this is the sport or the lifestyle that comes with sport, and that's a nuanced difference that I think is worth considering. The real challenge is that our treatment strategies for this disease at this point are all extrapolations from what we know about treating sedentary people, or they are accrued from expert experience. And I will tell you that decisions around things like rhythm maintenance versus ablation versus rate control are very different in a 60-year-old guy who runs a marathon or a 50-year-old woman who does triathlons than they would be in similar age people that just lead normally active lives. My sense is that over the next decade, probably the biggest breakthrough in the sports cardiology world is going to be to develop some primary data in this population to help us understand how to make these decisions, but obviously stay tuned to see if that materializes. So what about problems with the heart muscle? We have an active research program going in Boston where we leverage our student athletes to understand heart physiology. And one of the very first early studies we did was a study in a group of rowers who showed up and underwent training intensification. And we wanted to ask the simple question, does systolic function, the heart's ability to contract, change with exercise training? So we took a group of young men who were not exercise naive. They were good enough to make it to a collegiate rowing program, but who underwent roughly a tripling of exercise intensity and duration over a 90 period of time. And we did strain echocardiography on them before and after this experience. And what we were able to do is to develop strain maps, and these are strain maps looking in the three principal vectors of cardiac deformation. So longitudinal shortening, radial shortening, and circumferential shortening. Everything here in either gray or black indicates a gain of function, meaning things shorten better after training. But there was one exception, and that is in the interventricular septum, so the wall separating the left and right side of the heart, we saw a pretty clear and directionally consistent across subjects decrement and shortening in one vector, and that was the circumferential vector. And this was kind of looking like a fatigue signal. And what was really interesting is when we actually looked at the hearts, what we realized is these people that got septal fatigue were also the ones that dilated their right ventricles the most. So something was happening on the right side of the heart that was affecting the middle wall of the heart. And when we wrote this paper, we had no idea what to make of this. We put in 2 lines in the discussion about this probably being a clinical red herring and of very little value. And then a few years later, I got a call from a countryman of Sanjay's by the name of Greg White, who wanted to tell me about an interesting series he had put together in veteran athletes in which he had done cardiac MRI imaging with late gadolinium enhancement and found non-specific, non-ischemic scarring in these athletes' hearts. And lo and behold, it was in the same place that we had seen septal fatigue, meaning it was in the same location that in young people that had pushed hard over as short a period as 90 days, these older athletes had a scar in their hearts. That was followed very shortly thereafter by a really nicely done study by Andre Lagersh, who was at that point working in Belgium. And let me walk you through what Andre did. He took 40 trained athletes who were competitive folks. They were all finishing well in their races. They were all free of symptoms and risk factors, and none of them had any ischemia on echocardiography done beforehand. Andre and his group did cardiac MRI, echo, and biochemical analysis at 3 time points, before a big endurance race, immediately afterward, and then at some period after recovery, a week or 2 down the road. Here are the folks he studied. They were marathon runners, endurance triathletes, alpine cyclists, ultra triathletes, and they were incredibly fit, healthy people. So the majority of them were male. That's worth taking into consideration. They were fit, peak VO2s in the 140 to 160% age and gender predicted peak value level. So these are indeed accomplished athletes. And here's what happened to them after their races. So when you look at things like heart rate, blood pressure, pulmonary artery systolic pressure, there was clear evidence of physiologic perturbation that occurred after the race, meaning their heart rates were up, their blood pressures were down, and lo and behold, their right ventricles looked tired. They were bigger and they were less contractile than they were before the race. The majority of this recovered by that 1 or 2 week post-race study measurement, but indeed it was a very nice example of what this fatigue might look like. Here's a schematic that shows this, and what you can see from baseline to post-race is that the right heart expands. It does so by shifting the interventricular septum to the left and therefore decreasing the size of the left ventricular cavity. And what was most intriguing and probably most provocative about this study is that 5 of these 40 athletes had cardiac MRIs that showed scar on the heart. And here are the 5 representative examples. You can see the red arrows point to the scar locations. And again, the vast majority of this scar was located within the interventricular septum with a propensity to focus at the RV insertion hinge points, so the place where the RV and the LV meet as a potential area of weakness. So when you take Andre's study and take Greg's study and take some of our earlier fatigue data, I think there's some preliminary data to suggest that a small minority of chronic endurance athletes may develop this fibrotic cardiomyopathy. At this point, it's a phenotype, but it's a phenotype with really no clinical relevance because we just don't know what it means. Certainly deserves our attention and it requires further outcomes-based study, but as someone that sees lots and lots of masters athletes all the time, I'm not seeing a lot of people who present in clinically meaningful ways that have this when we look under the hood. Why might this happen? Well, if it does happen, it probably looks like this. It's the combination of chronic extreme volume and intensity coupled with training and recovery mismatch, i.e. not enough rest. There's almost certainly something at the host susceptibility level, probably in the gene pool. It's probably not ARVC genes, but again, that's still an area of some controversy. And then I would submit that if this happens, there's usually some secondary process, illicit drug use, infection, or some other form of cardiovascular disease. And let's not forget about uncontrolled hypertension here, because I think that's a big one. And if indeed this theoretical pathogenic cascade happens and the perfect storm occurs, it can look like this. But again, I think stay tuned. We don't know as much about this as we need to. And finally, my favorite one of all, and that's coronary artery disease. So I don't think I need to remind this group that exercise is the single best way to reduce atherosclerotic heart disease risk. And these are representative studies that show that when people exercise, the more they do, the more likely they are to move their cardiovascular risk factors in the right direction. So whether we're talking about reducing systolic blood pressure, improving plasma lipoprotein profiles, reducing central adiposity, exercise is good. And that's the single most important message for every single one of our patients. And what's fascinating that we learned from the Nurses' Health Study, as shown here by Sami Mora and Ayman Lee, that even when you account for things like cholesterol improvement, blood pressure reduction, it only explains about 50 to 60% of the benefit of exercise, meaning there's about half of the good stuff that exercise does we don't really understand. There truly is something magical about exercise for longevity, and right now that's still to some degree a biochemical mystery. I think many people are working on this and we're going to learn more about it, but exercise is good. So where does a study like this come from? This was published a decade ago in the European Heart Journal, running the risk of coronary events, and what these investigators did is took 108 men who'd run a lot of marathons, at least 5 marathons, and they did coronary artery calcium scoring with them using CT scanning. And what they were able to show was that when they looked at these marathon runners and compared them to controls that were matched for age and risk factors, that the marathon runners had more coronary artery calcium than these couch potatoes. Really controversial. And not only that, but the guys with the high coronary calciums went on to have meaningful clinical outcomes, meaning things that we as clinicians really care about, and I'll come back to that in a second. Second study done here in the US, published in Missouri Medicine, which I must admit I don't read routinely, but this was an interesting study. Increased coronary artery plaque volume among male marathoners. Here, marathon runners around 60 years age mean who had run 25 consecutive Twin Cities marathons. So these were accomplished guys. There's a lot about this group that wasn't reported in the paper. We know nothing about their training history, nothing about how well they did in the race, nothing about their physiology. But a similar and provocative finding, and that is that the male marathon runners had more coronary plaque than sedentary controls, and it wasn't only calcified plaque, it was also non-calcified plaque, which is the stuff we worry about more. So when you see studies like this, you basically have 3 interpretation options. One is that, and this is one that the authors of both studies gleamed on in the discussion, and that is that high levels of exercise simply cause atherosclerosis. Second, and perhaps alternatively, that traditional risk factors are truly causal and were underappreciated in these studies. Or maybe perhaps coronary disease is different in athletes. It looks different, it smells different, and it's driven by unknown and unmeasured risk factors. So let's go back to the marathon German study for a second, and let's look at the 4 people that had problems. Again, these were guys with high coronary artery calcium scores, 874, 472, 171, 128, and indeed they were accomplished athletes, 14, 22, 65, and 140 marathons, and they had events that we care about. Look at the events at the bottom of the screen. Ventricular tachycardia during exercise requiring stenting, stent and bypass surgery, another stent, another VT, another CABG patient. So these guys got sick. But let's look at them in a little bit more detail. So runner 1 had a total cholesterol of 344 and was a former smoker. Runner 2 was a medicated hypertensive. Runners 3 and 4 were both former smokers and unmedicated hypertensive. So I guess it's important to ask, do you really think it was the running that caused these men's coronary disease? Probably not. What about the Missouri study? Well, it's fascinating that the Missouri study was able to take these accomplished marathoners and find that more than 50% of them were former smokers. That's an important red herring here. And what's probably more concerning is what's missing from this paper. No mention of dietary intake, and I will tell you that most endurance athletes put anything into the furnace because they think if the furnace burns it, it's not important for their health. That is not the case. Macronutrient selection is an important part of health. These studies never adjust for what I call the carefree 20s and 30s, and that is the concept of men and women, but particularly men, not leading particularly healthy lives early and turning to marathon running as a way to so-called right the ship. What we do in our early years matters, and it sets up our health later on in life, and none of these studies ever do a good job addressing family genetics. So I think without controlling for these, can we really say anything about causality? Probably not. Now, things are getting more complicated, thanks to my good friend Dr. Sharma and his group and some other European investigators, and that is we are now realizing that coronary calcification in masters athletes is indeed something we have to pay attention to. And I just want to show you very briefly these two studies that were published in Tandem and Circulation a few months ago, and perhaps in the question and answer session, Sanjay, we can talk a little bit more about this. But the finding was basically the same in these two cross-sectional studies, and that is that male athletes tended to have more coronary calcium than non-male athletes. And in the second study, which was not done by Sanjay's group, there seemed to be a dose relationship between levels of calcium and how much exercise people reported in self-reported questionnaires. So these are cross-sectional studies that show more calcium in marathon runners or in exercisers' arteries than in non-exercisers. And so this is thought-provoking and pause for concern. We only have one longitudinal data set, and it is a very, very small and I would say at best hypothesis-generating data set now available. And this was some work that we did here in the US with a small group of men and women who decided to run from Huntington Beach, California to Baltimore, Maryland by doing a marathon a day for 6 months. And we studied them with coronary CT at UCLA and then again at George Washington when they finished their race. And our hypothesis was that these middle-aged men and women were going to have some coronary disease when they started, but it was all going to go away because doing basically a life's worth of exercise in 6 months was going to make them as healthy as anyone could possibly get. But somewhat to our surprise, not only did it not go away, but in folks that had it, 4 of the 8 people started with some coronary disease, and 3 of those 4 people who had it got worse during the course of this run. And not only was that interesting, but the folks that got worse did so were also the folks that had the highest inflammatory biomarkers. So something about these people that started the race with coronary disease and developed inflammation during this exercise challenge also stimulated the development of some coronary disease. This is, again, something I think we don't really understand in some detail, but I will say that it does at this point appear that coronary calcium and subclinical plaques are more common in people that exercise hard than those that don't. But true garden variety coronary disease that kills people, causes myocardial infarctions, requires revascularization, is something I think at this point we cannot say is caused by running. And let me give you my take home of how this looks. So this is Mount Washington. It's the Mount Washington road race, and you can see the profile here. This is a 7.6 mile race that covers about 4,000 vertical feet over that short period of time. I took one of our fellows there a few years back because she didn't have an endurance sport background and really wanted to learn about endurance athletes. And I said, just come with me, keep your ears open, you're going to learn a tremendous amount about these people in the couple hours we're up there. So we got out of the car, and I'm not going to tell you what happened in the porta potty. I'm going to tell you what happened as we were waiting for the porta potty. A conversation erupted in front of us, which I think captures the essence of why coronary disease develops in masters athletes. And here's how the conversation goes. Guy 1 says, man, not so sure that second plate of chili nachos and the extra couple of beers last night were such a good idea. Oh, well, they always say don't change your routine prior to races. So this is an issue of diet, and again, this is a poorly underappreciated problem among athletic people as they start to get older. Just wish my old man could see me now. He died at age 45 from a massive heart attack. Glad I got my wake-up call. Bad stuff runs in my genes. Again, this is an athlete that's very appropriately and commendably turning to exercise to mitigate a genetic risk, but you can't run away from it completely. Well, regardless of what happens, I've got to be better off than I was 20 years ago when I was smoking a pack a day and got short of breath just driving up this damn hill. This is an example of someone who made poor health decisions early in life and is righting the ship, and although that's commendable and we should support that, it doesn't completely reduce risk and it does not confer immunity. And then the best one, cough, cough, cough. If this race wasn't only once a year, I'd be home in bed. I feel like shit. Oh well, this little climb will help me clear out the junk. So this is the one that bothers me the most. This is an athlete that's making a deliberate decision to run 4,000 vertical feet over 7.5 miles in the midst of a viral infection. Remember, when your nares and your oropharynx are inflamed, so too are all of the vessels in your body. So if ever there's time to destabilize a coronary plaque and cause a myocardial infarction, it's in the context of an active viral infection, so bad idea. So is running really the main causal issue? Probably not. Does it cause a little bit of coronary calcium? Probably so. Should we care about that? I'd say stay tuned until we actually have some hard outcomes data. So let's go back to this and put this all into what is my personal synthesis of this controversy, and that is, can we get too much exercise? The answer is, for the vast majority of recreational and competitive athletes, no. They will live in this margin of safety and enjoy all the benefits of being fit, being active, and competing without any problems, and they will live long and feel great. Coronary disease exists in this margin of safety, and I would submit that the vast majority of clinically relevant coronary disease is not a function of too much exercise, but rather a function of the traditional risk factors and maybe even some unappreciated risk factors that athletes bring to this equation. Atrial fibrillation is the only good example we have at this point of a so-called overuse pathology. It's out there, it's alive, and the harder we push and the longer we push, particularly as men into our 40s, 50s, and 60s, the more likely we are to have this. I wake up every morning and check my radial pulse because I know it's coming. And then finally, this issue of toxic exposure. I think that there are some preliminary data that would suggest that maybe some scarring can occur in the context of lots of exercise, but again, at this point, we don't really have a good clinical context to understand what, if anything, to do with this. So in the meantime, as we're learning more and as data are emerging, as I said, we are in this debate now, and hopefully 10 years from now we'll have more to help us reconcile. I think the best approach to this problem is with common sense, and I'll give you the 7 rules of common sense that we use with our patients. First is to address cardiovascular risk factors. The biggest mistake we can make as clinicians is see the healthy, active masters athlete walk through and ignore a blood pressure of 140/90, or ignore an HDL cholesterol of 20 or an LDL of 170. These things are real, and if they're not addressed, they will catch up with people and cause atherosclerotic disease. Discussing health versus performance. All of my patients run, cycle, swim, and do so with vigor, but at the same time, I've never told anyone they have to do this to be maximally healthy. It turns out that there's no reason to dissuade people from doing this, but maximal, optimal cardiovascular health can probably be obtained by simply adhering to guidelines, and again, that's 150 minutes of moderate intensity activity a week. Annual periodicity, I have no primary data to point you in this direction, but I will tell you that most of the folks that I work with that enjoy longevity over many years have figured out a way to rest and recover. And so we typically recommend people spend at least 3 months of the year in a phase of active recovery, which we define as a reduction in both volume and intensity by at least 50%. Warm-ups and cool-downs. We've talked a lot about sudden death during this conference, and one of the things we haven't really addressed is when it happens. It typically happens on the shoulder ends of exercise within the first couple minutes, or in the first couple minutes after it stops. A lot of this risk can be mitigated by appropriate warming up and cooling down. Event preparation is a no-brainer. When you're 20 years old, you can wake up and go out and try to run the Boston Marathon without preparation. As we get older and we intercede coronary disease and other potential risk factors, this is a bad idea, and event preparation is an important way to reduce risk. Respecting a virus, I talked about this one. Again, not a lot of primary data here, but over and over when I meet particularly men that present with acute coronary syndromes, one of the things they tell me is they felt crummy beforehand. Could it have been staggering ischemic symptoms? Sure, but a lot of time it sounds really viral to me, so I pay careful attention to this. And finally, again, probably the most important message to give to our active patients is to listen for warning signs. If the body's telling them that they can no longer do something that they used to do easily, that is pause for concern, and we need to take them seriously and make a decision about what needs to be done diagnostically to clear the air to find the diseases we care about. So I will finish with that, and I appreciate your attention.